Good morning. Welcome to this episode of Guts and Glory, where we dive deep into the world of GI and HPB surgery. Today is World Women's Day, and how apt it is that we have one of the leading figures in world with tremendous contribution to women empowerment in surgery. Let me introduce Professor Catherine Teh, a trailblazing HPB surgeon from Manila, Philippines, who is a global leader in fluorescence guided surgery and minimally invasive HPB oncology surgery. She has been honored with many awards and distinctions, which is a whole lot of them and difficult to recount all of them here. But a few of them are the first Filipino to be included as an honorary member, fellow of the American Surgical Association, SSAT Distinguished Service Award, and she's been rated as top 3 researchers globally. I'm so delighted to have Catherine on this podcast. Catherine, welcome to this podcast, which I'm going to title it as Revolutionizing HPB Oncology to Global Mentorship, Empowering the Next Generation.
Thank you so much. Thank you very much for having me today in your podcast, and really I'm very honored, and I feel indeed very apt for today, for this celebration of International Women's Day. I am very privileged, I should say, I'm very privileged to be able to lead, to be able to share my journey, my experience, and to be able to influence the younger generation.
Absolutely. Yes, I've seen that many times when I've met and seen a lot of people around you. And I realize that you play a remarkably inspiring and empowering role on this global stage. My question is, how did this journey begin? What influenced you pursue this path?
I think I need to look at it in two different stages, where the first stage really is that one needs to be a physician first. So I really wanted to be a doctor since I was young. My mom told me that I wanted to be a doctor since I was 3, and it really never changed.
Wow.
But then to get into this global stage, to get into the HPB scene, and to be working alongside most of the pioneers and giants in the field of HPB surgery, it really was not purely by design, but an interaction between chance, opportunity, and really taking that opportunity and transforming it into something worthwhile. In fact, I wasn't really planning to be an HPB surgeon. The fellowship training that was available and were taken by many others were breast, upper GI, and all the rest. But HPB was empty.
Right.
So that's the reason why I took it, thinking that I'd have better chance, and that was in the early 2000s. So HPB was still in its beginning.
Fancy. Yes.
So yeah, so that was the opportunity at the time, which I took.
To be at the right place at the right time.
It's at the
And
right place
taking
at the
that
right time.
opportunity. I think that
That's true. Yes.
Yeah.
Yes.
But I want to know about your days of surgical training, in the sense that, these are difficult areas. How did you navigate that phase to build the confidence and the skill set which you have developed over the years? I mean, specifically, when you do this training, you go through this long period, you need a good support system and
Yes.
a whole lot of mentors. So tell
Yes.
us something about this support system, mentors, and your phase of training.
Yes, it was very difficult in the beginning because I came from a low middle income country, and as we said, that HPB surgery was not very common at that time. So all I saw was wedge resection, a lot of bypass surgeries, and in our side of the world, most patients come at a very late stage. So surgeries of this magnitude today were not really seen before. So when I was during my fellowship, my mentor, and as you said aptly, mentorship is crucial. My mentor was the best, and really, he from Singapore General Hospital, he gave me the guidance in technical, non-technical, academic, research, everything. And I remember there was once
Mentorship. Yeah.
yeah, there
Yeah.
was once he told me, he said, you don't really need to be the best in doing everything in your skill, but you need to make sure that you understand what the patients are going through, they understand what the problem is. You need to build this connection with your patients. So you see, it wasn't really truly a mentorship just for skills alone. It was 360 degrees, everything all
Yep.
around, being a good physician, being a competent and a compassionate surgeon who would also be able to align with what is current and what is developing, and to be able to adapt to change. So what my mentor taught me from then on really has shaped who I am today.
Mhm.
And because I was not really able to feel that when I was younger. When I was, when you're a resident, you just want to go through it. You just
Yes.
want to go through your residency and
Yes.
emerge successful. But in fellowship, that was a time when I really had the chance to look into each patient, into each case, and reflect on each case, what went wrong, what went well, and how could we have done things better. At each stage, I meet the best mentors in the field. And until today, I go back to them, and we really establish that connection and that support system. And I think that's what truly matters.
You're absolutely right because a lot of times the residents and fellows get caught up in acquiring the skill, the
Yes.
holistic development, and which is very critical because
Yeah.
skill a lot of people can acquire, but
Yes.
the looking at the problem and how to adapt to the problem to a particular patient, I think that's what mentorship gives. And
Yes.
I quite agree with you in
Yeah.
that sense. But
Yeah.
Catherine, tell me, like, when you are doing HPB surgery, uh, you know, what barriers do HPB surgeons face, especially women surgeons? And how do you, how did you deal with it? And how do you help people now at this stage to, get through this HPB conundrum?
Because at any point in time, all the challenges that come with it, and especially as a woman, and especially as a woman in HPV,
Yeah.
where at that time, really there was extremely little number, almost none, during that time
Mhm.
when I was a fellow. Number one, you need to build that support system during during your training, after your training. Of course, being a woman, one of the, we've had several surveys, and one of the surveys that we've looked into last year were the barriers.
Mhm.
Up to 70% of the barriers were about childbirth, about family, about mental health, and this is where family support really comes in. I think mainly number one is to be able to recognize that there are barriers, and we just need to accept this vulnerability. We do not have to
Inevitable.
force, or yeah, we don't have to create this front, because we need to tell people that we need support, we need help, and there's no shame in it. And as a woman, sometimes we feel that we know it all, because this is the maternal instinct. I think in Asia, in India, and even in the
Yeah.
Philippines, I think it's the same. We also don't want to feel burden to other people, because we are so used to caring for other people.
Yes.
But it is necessary for others to know that we need help too. So that is something that I would like to share, letting people know that support is needed, especially family support in the reproductive age. Professionally, it's important to develop collaborations. We cannot advance just by ourselves.
Yeah.
So being able to establish network and create opportunities for collaboration will definitely help us overcome the barriers where we're in. If you are not in a very strong academic environment, then these will definitely help. Thirdly is clinically, there will always be challenging cases. Do not, I never felt inferior, and I never felt like it is embarrassing or it is a shame that I don't know. I would always I would
Yeah.
always call a
Yeah.
friend. I'd always go back to my mentors and say, "Hey, I have this case. I
Yeah.
saw this, and I'd like your opinion." I may not follow the opinion, but at
Yeah.
least I can pick somebody else's brain. So
Yeah.
I think it's important
Yeah.
to do that. So many developments in genetic profiling and targeted systemic treatment that really develops and advances at a very, very fast pace with immunotherapy. I feel some of us as surgeons are lagging behind. It's because we feel that we need to operate and we need
Yeah.
to behave as surgeons. But in reality, it's not all about cutting. We need to know biology, we need to know many other things alongside surgery because we need to integrate this treatment as a holistic
Yeah.
approach. Yeah.
No, I think you make some very important points. Basically, what you said, no, that you should not portray a picture of that you can do it all, and asking or saying I can't do this is a sign of weakness. That cannot be true. And I think the other point reflects the fact that in HPB and in modern times, you need to work collaboration and have good teams, isn't it?
Yes.
Unless you have good teams, you can't produce results. It's not a single handed person. So, yeah, I think these are very important points which you raise. And
I also wanted to share with you something about because you mentioned about teams. And in the
yes,
beginning, when I came back, and I felt like I know a lot more than what I used to know, and I know that I have honed my skills much more. But the truth is, my outcomes are not as great as where I came from. So it all boils down to developing your team.
yeah,
If your team members, if your anesthesiologists, your nurses, your administration, medical departments, gastroenterologists, your radiology, if they do not upgrade and they do not come upskill and align with you,
develop
you
along with
will
you. Yeah,
no, you will never achieve the
lag
outcome of that.
behind.
Yeah.
Yes,
So it's really a team sport, and we need to use our passion to try to influence others
yeah.
to be aligned and work towards the same goal. It's
About
always a
leadership,
systems
isn't it?
approach. Yeah.
It's about leadership. Yeah. So, I mean, just continuing with that, Catherine, that you've been at the forefront of this minimal invasive sort of revolution in HPB oncology with laparoscopic and robotic domains. If I ask you that, what do you think is the contribution which you are very proud of, or you feel that you have made a tremendous contribution in this field? I want to hear from you. According to you, we know a lot, many of them, but what do you think?
I think one of the most important contribution I feel that I've shared and I've done, at least locally, is that I do a lot, a fair bit, almost 90% of my work has become minimally invasive, even in complex situations.
Problems. Yeah,
I was able to contribute 65 cases of complex Iwate complex cases of more than a score of more than 10, which is only for experts. I'm the only woman who has contributed to that in the entire world. So I think that is one contribution for laparoscopic liver resection. More importantly, I think to be able to show women that we can coexist in this field and we are able to do it as good as the rest.
And better.
I think that, or even better, yes. I think that is one of the most important contribution for me as a woman, as a surgeon. Doesn't have to be a
Certainly.
woman, but as a surgeon, also coming from a low middle income country, because we do a lot of creative approach compared
Mhm.
to the
Yes.
standard approach where they have everything
Yes.
in the West, but to be able to pursue and to be able to achieve these complex laparoscopic liver resections, we need to think out of the box. We need a lot of creativity because we have minimal instruments and we're still able to do it. So I think
Yeah.
it really boils down to me is if there's a will, there's a way.
And we call this jugaad in India. So jugaad means to sort of make up what is lacking by some local things,
Yes,
and
that's right.
that's what it is. But I don't know. I mean, I'm talking from what I see around me. There are a lot of surgeons are still very hesitant to embark on minimal invasive surgery for complex diseases, HPB diseases. As a matter of fact, if you look at pancreatic duodenectomies being done across the world, only about 20% are being done by minimal invasive means. So my
Yes.
question is, what convinced you to push the boundaries and adopt this in the scenario that you were, evolving as a surgeon or developing as a surgeon? And how did you know it was the right direction to choose?
Yeah. So, firstly, I think it all boils down to challenges and frustrations. When I started, I I don't get referrals. Patients don't come to me. Patients ask me, "How many cases
How
have you
many you have
done?
done? Yes.
How old are you?" I don't need to be asked these questions, right?
Yeah.
But these are the common questions that I get. And
Yes.
even if I sit in my clinic all day, I do not receive any referral for a liver or a pancreas, but I do get referrals for excision of lumps and bumps. I would get referrals for hemorrhoids, for bed sores. So I did not train for those. To me, in my
Yeah.
mind, I did not do my training just to do all these. So I need to reinvent myself. I need to think of something, and how can I make myself different from the rest? So
Right.
every surgeon,
Doing.
will know how to operate. But how can I make myself different? So that was the time when I thought I needed to do something more than what the rest, my seniors, are doing. And that was how I came into minimally invasive surgery
Mhm.
and really pursued, no matter how difficult it was. And when we look at all the consensus guidelines, you see, all the guidelines come down to how to deliver safe laparoscopic liver resection, how to deliver safe pancreatic duodenectomies. Any any of those consensus guidelines all boils down to safety, and perhaps that's the reason why the pickup rate is so slow, because we ourselves are very hesitant to diffuse it widely because we know that the learning curve is very steep,
Yeah.
and patient safety is paramount. So, and even today there's still a lot of debate about laparoscopic
Yeah.
open. So I think that's also one of the reasons why it takes a while before this really becomes a
And
more
yeah. Yeah.
adaptable. Plus the cost of all these instruments that's needed, because without I mean, without the energy devices, it's impossible to do a
Yeah.
minimally invasive liver or pancreatic resection.
No, also, one of the common arguments against it is that a surgeon who has experienced and learned to do a procedure well in a particular way, now if he or she has to go through another learning curve with the minimal invasive, so how does it weigh in with the patients? Like, you know,
Yes.
I, I'm very good at this, but now I'm going to do this, and your results may not be as good. So, that may be one of the uh, something which holds back people to adopt that. This is what I feel, and I think I hear this around a lot.
Yes, I think that's also one. But it will change
Yeah.
because this every I'm sure you also hear this because every time patients ask, can you do it minimally invasive?
Yes.
Can
Now
I
they're
have a
asking for it.
laparoscopic?
Yes.
Yeah. So patients ask for it. So I think in the next few years it will change. I just don't know how training should be and how training will happen when we come to the age just like laparoscopic cholecystectomy when
Yes.
our trainees
Open.
nowadays don't even know how to do it open.
Yes, yes. But just continuing with this, Catherine, when you offer minimally invasive surgery for HPB oncology to patients, of course, they have a lot of questions. And so, what guides your approach? Is it all comers minimal invasive? You offer open, you have an option, robotic. I mean, how do you choose?
It depends on the phase as well. In the past, when I was just beginning, I started offering them to highly selected patients, in patients where I know I would be able to do the minimally invasive approach successfully, such as those, as in the guidelines, periphery, left
Yeah.
lateral, segment 4B, 5, 6, things like that. Although I have to admit that at one point in time, I wasn't really following the guidelines accordingly because I have a vast experience in open. I felt that I knew how to go through it, and also because of my training in advanced laparoscopic, which I was doing bariatric surgeries, colorectal surgeries.
Mhm.
So transferring of skills
Yes.
uh, for HPB was probably one of the reasons why I was able to adapt very quickly. So, so at that point, what I did was, and I still advocate this, is to do it on a stepwise approach, meaning that in very complex, let's say we are faced with a right hepatectomy for a big tumor,
Yes.
the approach will be such that very candid and very honest to the patient that we will try laparoscopic approach,
Hmm.
but in the event that there is any safety issue, I will have to convert.
Convert.
So I always tell the patient that in the beginning,
Hmm.
first 2 years, 2 to 3 years of when I was starting laparoscopic approach, especially for big tumors and for major hepatectomies like that. But what's important there is building confidence. It was important to build the confidence step by step because these are the times when you tell yourself in your mind that you will most likely convert at some point in time, but
Right.
not when the patient is crashing. It is up to a certain level where you cannot proceed as planned. But also, there are certain times when you would be able to do this stepwise in a way that you can achieve Pringles, you can achieve parenchymal transection, you can achieve vascular
Isolation.
occlusion,
Hmm.
yes, and ligation. And sometimes the only thing that you won't be able to finish is towards the end, especially in the large tumors
Yeah.
where it's very difficult to approach the hepatic veins. But having said that, you have minimized the incision because it was only parenchymal transection was already almost finished.
Yes.
So these are a lot of times in the beginning this was happening, but my patients still appreciate it because it's what's important really is that relationship with your
Relation.
patient
Absolutely.
and the honesty that from the very beginning they know what to expect and you also know what to expect, even your anesthesiologist, because we don't want crash conversion.
Conversions electively rather than as a
Yes,
uh,
yes.
emergency
Yeah.
need. But conversions, how do you view conversions? I mean, in terms of, you know, as how it impacts the outcome and how it impacts what patients think about conversions.
So we looked at our data actually. Even if we converted all of our conversions, patients still do better and patients still go home. I mean, their hospital stay is still 1 or 2 days less and the
Mhm.
pain is still less. So the conversions in this scenario, we're not talking about crash conversions and unexpected conversions. We're talking
Yes.
about expected conversions. Or should I say the better term is like a hybrid approach
Yeah.
more than conversion. So in this scenario,
It's a
patients are
planned approach.
it's a
You
planned
do.
approach.
Yeah.
Yes. So it is important to be able to strategize fully prior to surgery and make sure that your plans are in place.
Yeah.
Option A, option B, option C,
Yeah.
and not be surprised at all. So
Yeah.
everything has to be strategically planned. Yeah.
As they say now that we do most of the surgeries before the actual surgery and have
Yes.
everything sorted out. And as you said, have all the
Yes.
plans in place.
Yes, that is so true because every surgery that I schedule um, actually happens in my mind before the surgery happens.
Yeah.
The night before, and I even joke about this with my trainees. I tell them, I'm constantly dreaming about the scan of my
I
patient
know
and
what
about
you're
the
saying.
procedure that I'm supposed to do at 7 o'clock in the morning.
Yeah.
So it's in my dreams
Yeah.
every night.
Even if it is the 150th liver section.
No
Yes.
matter which number it
Yeah.
is, it happens all the time, and
Yeah.
I still cannot do away with not flipping a book or a reading something just before the operation, just to make sure that am I not missing anything, going through all the data, and also something
Yeah.
might be helpful. So it's been a habit. I think it's
Yeah.
habit forming. Yeah.
So, Catherine, I want to take you back to what you said as the transformative contribution or so, which is the ICG revolution in HPB surgery. I remember I heard you in Korea a couple of years back, and I mean, actually, the whole hall and everyone was really astounded by the data which you presented. So, how did you pick this up? How did you get into this ICG scene? And what do you think now has been its impact and utility in HPB oncology?
I was actually very skeptical in the beginning. And as any surgeon would say, I don't need it. That's what I said as well.
Mm.
So I was agnostic in the beginning, but I just fell in love with it when I tried it. So one of my colleagues brought it in, and he said, "You should try it. If you want to do your livers, why don't you try this even for your gallbladder?" So I first used it to identify a tumor because it was a small tumor from a neuroendocrine. Um, it's a neuroendocrine metastasis.
Mhm.
So I wanted to see if there are tumors elsewhere. So I used it to identify the tumor, and subsequently I was so happy because it really showed me where the tumors were.
Mm.
One tumor that I did not see on the scan and led to another. So that was like, very, very magical for me. So indications change. The way you use it change over time. So in the beginning, it was purely to identify the tumor, and then next to identify the segmentation,
Yes.
helping in precision hepatectomy, and then there was an incidental or accidentally, I also saw a variant, a posterior biliary segment 7 duct that was arising from the left with the ICG. It was
Mhm.
it was all by accident. So the more I use it, the more I realize that
And
it
the
is helpful.
yeah,
And that's why I became such an advocate of it. And really it is an additional tool that in our toolbox, if we have the ability or if we have the capability and the resources available,
good.
why not, right? Because it can only help us see better, and
Yes.
once you see better, you can do better. People ask me as well, like, why do you use it routinely in laparoscopic cholecystectomy?
Yeah.
And in the beginning when I used it, it was out of novelty. So the more I used it, then I realized that we are able to identify more and more variants of the biliary tree. And then it was such a great tool for teaching and training.
Yeah.
Every person in the operating room, whether it be a student, a trainee, a surgical trainee, a nurse, they can see what we're talking about.
Yeah.
And and if we think about it, a patient for elective, so people ask me, even for elective, and the truth is even more so for elective, because these are the patients who should not have any error, who should not have any bile duct injury at all. and
Mm.
if and if for a fraction of, I mean, for an additional cost, it gives you peace of mind, it makes sure of the anatomy, and it improves safety. We're not saying that this can absolutely prevent bile duct injury, but definitely adding one layer
Yeah.
of safety.
Definitely.
So
I'm a great fan of ICG, and I use it quite liberally. And we have done
yeah,
work in acute cholestasis. And
yes,
we looked at direct ICG injection in the gallbladder, because sometimes if you don't give pre-operatively, you may not be able to visualize. So whether we can do it like a cholangiogram and things like that. So I love ICG. I love the colors it shows on the screen. So, and as you said, everyone can see it. So fantastic. That
I
is,
think it's really a good tool that lessens your cognitive workload. A
yeah,
lot of people who don't use it, they keep saying, I don't need it. I know what I'm doing. It's
yeah,
sometimes it's not about just knowing what you know and what you're doing. There are several factors, even environmental factors and
yeah,
factors that sometimes we don't know or we are unconscious with, and it
yeah.
impacts our decision making. But with something adding a layer of patient safety, I think it's crucial.
Absolutely, absolutely. I agree with you. Uh, Catherine, you have so many firsts to your name that it almost seems banal to count them. But I want to hear about the HPB cancer care in Philippines, which you have brought a transformation by getting all stakeholders together, ensuring equity of care. So tell me a little about it, because how you've brought this together and what has been its impact.
Actually, we started with the National Integrated Cancer Control Act. So it is for shaping the cancer care landscape in the Philippines. And in fact, more recently, your colleagues from India to share with us your experience in the National Cancer Grid
It's a grid.
of India.
Yes,
Yes.
yes,
So that is the same path that we are looking at. So we started with the National Integrated Cancer Control Act in 2019. And because of that, for the entire for all the different cancers in a general cancer care aspect, I had to segue into the HPB aspect because HEC is very common in this country.
Yeah.
And we don't really have any guideline of any sort, so I put it up to the Department of Health to come up with a national guideline for hepatocellular carcinoma. Together with our hepatologist, we created or we actually advocated for what we call as a Liver Cancer Awareness Month. So every
Mm-hmm.
January, from then on in 2020, we call it a celebrate, but we
Yeah.
enhance the awareness, prevention, screening, early detection, and so we involve also the lay people, which we call as the yellow warriors, because they are these are patients with hepatitis. So
Okay.
hepatitis B is incidence is very high. It's endemic in our country. So we have these yellow warriors who are together with us, advocating for increasing the awareness
Well,
on. Yeah.
yeah.
And then with my involvement in the Cancer Commission, because I'm the director at the Cancer Commission, we also hold these kinds of multidisciplinary tumor board nationally, uh,
Mm-hmm.
for all the diseases, all the different organ systems. But in terms of HPB, we include also biliary cancer, pancreatic cancer, colorectal, liver metastasis, and primary HCC. So those are some of the things that I have personally been able to
Yeah.
move
Yeah.
things forward. Yeah.
Fantastic. You know, I was doing some research and uh, maybe I could address you as a modern day Babylon in Filipino tradition because of your desire to, serve the community, look after their well being, for justice, equity, all those things. What do you think? That is apt title for you uh, in the modern day?
It's such a privilege to be given that title, but really what I feel is that each one of us, all of us, would really have something to offer um, in our own little ways. Whatever that I do is very small. It doesn't really. I don't think it's a huge contribution, but the truth is that no matter how small our contribution is, when we put everyone's small contribution together, it becomes big.
Yes, absolutely. Yeah. Uh, Maybe some final thoughts now, Catherine. For trainees and fellows who are aspiring to be HPB surgeons, I mean, what do you recommend as timelines in training and methods to adopt? Like, I'm sure you have a fellowship program. So, how structured is it, and uh, how do you sort of figure out that they've come to the appropriate level of skill and proficiency?
So we do have a very structured program in the country. So this is created by our association, by the Philippine chapter,
Mhm.
and every trainee. I think it's important for the trainee to know that at certain levels of their training and proficiency, they will see things differently. As a fellow HUB fellow in training, it is important to learn the necessary advanced skills for complex HPB with integrating the current advances in the clinical application, but also need to contribute back to the community by looking at our outcomes and how we can improve it. And these can contribute to research. Mentor, teach others,
Yeah,
train others, and not only within the country, but also share our outcomes and share your views, your experience internationally in the global stage. So I think
yeah. I think, and also, I feel, one of the things in modern times is you have to continuously upgrade your skills and knowledge, because you
Definitely.
can't just sit on that. As you mentioned, that think the landscape is changing so fast,
So fast.
non-surgical things coming in, that you can't just sit back and say, I've become a fellow, I've learned from Catherine Tay, and now that's it. I don't need to worry too much about it. But going on mentorship, I, I know that you would be mentoring again as a holistic thing. But what is that one thing do you continuously emphasize on your trainees or fellows when they pass through your portals? Some one thing which you may tell them all the time.
Um, I think one important thing that I always tell them is to ask them to look inwards, reflect, and see um, how they can make a difference. Because first we look at the precision in surgery. Definitely, I make sure that they are up to date, they are precise, they use technology to their advantage.
Right.
Second is that you need to know how to integrate biology with surgery. It's not all about surgery. So
Yes.
my trainees know that I'm always talking about biology, talking about NGS, the ctDNA, talking about systemic treatment, and all of
Right.
these. Last but not the least is systems innovation and integration. We must build healthcare systems that would allow complex care, complex cancer care to reach more patients, and especially in the less accessible, less resource area. So those are the three things that I always tell my trainees.
Catherine, thank you so much for being on this podcast. I've really enjoyed this conversation with you, and I'm sure the listeners would feel very, very enlightened to listen to you. Thank you so much.
Thank you very much for having me. But also in the light of International Women's Month, because I think it's important to sort of encourage our women viewers or listeners. We used to always talk about whether how to gain equity,
Mhm.
right? But
Mhm.
I think from now on, we shouldn't be thinking about it. I think the most important question really is that we do not have to think whether we need to ask for having a place in the operating room or in a table, but we just really need to show up, go lead, innovate,
And own
go
that
for,
place.
yes, own the place, and together I think we can reshape the future of surgery. Yeah.
Thank you very much. Happy Women's Day.
Thank you so much for having me. It's really an honor.